morning or good afternoon to everyone, depending on where you are joining us from. Welcome back to N4's first ever professional development series on trauma-informed care. This is session 3, trauma-informed care considerations for organizations and systems. Before we begin today's event, we would like to begin with an acknowledgement that N4 is hosted at CHEO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin-Anishinaabe territory. The peoples of the Algonquin-Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Mariah Maddock. I use the pronouns she and her, and I am a project coordinator on the N4 team. I will be introducing our facilitators today, and our co-host is Andrew Tomeyer, and N4's education coordinator, and Andrew will be monitoring the chat box today. And if you have any technical issues during the session, please feel free to send a direct message to Andrew or I, and we will try our best to support you. And I'm really pleased to be welcoming back our facilitators who are all a part of the trauma-informed care team at IWK Health Centre in Halifax, Nova Scotia. And so joining us today is Holly Murphy, Advanced Practice Leader of Trauma-Informed Care with the IWK Mental Health and Addictions Program. We're also welcoming back Laura Callaghan, who is a nurse practitioner in pediatrics with IWK and ISANS with the IWK Mental Health and Addictions Program. Welcome back, Laura. And also is Prasanna Kariyawansa, registered social worker, program educator with the Trauma-Informed Care team and IWK Mental Health and Addictions Program. Welcome back, Prasanna. So we are recording today's session, and we will upload it to our N4 platform with the accompanying resources for the session. We will share this with you as soon as it becomes available. However, we will not be recording the breakout rooms today. So we will resume the recording after the breakout rooms end to ensure a safe space for dialogue. And just some general housekeeping. Please keep yourself on mute, but feel free to unmute yourself, of course, if you have questions or when you're in breakout room sessions. Use the raise hand feature to ask a question or to make a comment, or feel free to put your questions or comments in the chat box. There were a couple of you who contacted me letting me know that you won't be able to unmute yourself in the breakout rooms. So please feel free to use the chat box if you'd like to. And while we encourage you to turn on your video today, it is completely optional, so please do what feels right for you. And our session today will begin with a short didactic from our facilitators, Laura, Holly, and Prasanna from IWK. And then Holly will introduce the breakout room activity. We'll go off into our breakout rooms, and like our last sessions, we'll come back and do a report back and then wrap up with some take-home messages. And with that said, I am going to pass it over to our IWK team.
Thanks so much, Mariah. Just gonna switch slides here, folks. Bear with us. All right, perfect. Welcome back, everybody. Good to see you folks here. So I'll get us started off. So before we get into our content, similar to the other two sessions as well, I want to acknowledge that we're in Mi'kma'ki, the unceded and ancestral territory of the Mi'kmaq people. And I thought in session 3, just as an additional consideration, I'm going to get you folks to absolutely think about which communities you live in, which Indigenous communities you live in, but then also reflect on your own own experiences with colonization as well. So that's something that we've been talking about, is not to just assume that folks that may be living in Canada who aren't an Indigenous person may not have their own experience of colonization. So only if that applies to you, to kind of reflect on that. And the other thing I thought I'd share on this slide is, if you haven't already, is to consider looking at the Truth and Reconciliation Calls to Action, which is a federal document that's out there. You can just Google it if you're not familiar with it. But then specifically for this demographic, and the focus of N4 is to look at number 93 and 94, which is call to action for the federal government to ensure that any newcomers are aware of the colonial history of our Indigenous peoples. And then number 94 is a call to action to the federal government to actually change the citizenship oath that individuals take when they become a Canadian citizen. So I thought, I'm just gonna put that out there as well, in case you folks aren't familiar with those two calls to action. And one of the main reasons, so based on my own experience of coming to Canada as a newcomer, I didn't really know anything about the colonial history of Indigenous folks for a while, I'd say, until I started to do my own self-directed learning. So I'm excited that it is included in the TRC as well. And Holly, if you can go to the next slide, please. And in terms of the guidelines, if you will, for the session, it's the same as the content we had in the first two sessions. So the invitation is to be as comfortable as you can be wherever you are, knowing that this is being delivered virtually, as similar to the last two sessions. So there is no formal break, as you saw in Maria's itinerary, but please feel free to do what you need to do to stay physically regulated and comfortable. And then given the content and the topic, the invitation also is to do what you need to do to feel psychologically safe, even within the context of this learning environment. Okay. And Holly, if you can go to the next slide, please. So we're going in a progression here, and the title probably gave it away. So today's objectives are going to be to think about applying the theory behind, well, the broad theory of trauma-informed care into our specific organizations, as well as thinking about the application of trauma-informed care at a cross-sectoral or systems level as well. Because I know, regardless of which sector you folks work in or work for, there's always going to be the need to collaborate as we support our clients, right? So regardless of what your role is, profession is, or the organization you belong to. So in terms of the content itself, I'm going to do a very, very quick review. So in session one, we looked at the orange-ish circle in the middle there. So the application of trauma-informed practice, and specifically the principles at a broad level to clients and families. And in session two, we looked at the application of the exact same 5 principles to ourselves as care providers and our teams. And Holly will spend a little bit of time today talking about further considerations at an organizational level today. And then Holly, if you can go to the next slide, please. So as a quick recap, we talked about for trauma, it's not really about a diagnosis of trauma or focusing on the treatment of trauma or past experiences. It really is about assessing the current coping strategies or ability to function in the moment as your clients are interacting with you or you're interacting with your clients. And the exact same thing applies to us as well as peers or coworkers, whether it's within a team, within an organization, or with other organizations or teams, is to think about your own lived experiences and your own ability or needs in the moment to manage whatever stressors or adversities you may be experiencing. And then the second bullet point talks quickly about it's not just at an individual level, but then thinking about it at a social and collective level as well. And then when you're thinking about trauma-informed care rather than trauma. I already talked about the fact that it's not really about the treatment of trauma, but it is taking this systemic approach. So being aware of what trauma is really important when you're thinking about application. You got to be thinking of also not stigmatizing individuals and just assuming that, right, just because a person has a refugee status or came from a country of origin where there may have been a war or other major adversity, that they're automatically traumatized, right? So that's going to be bulk of what we're doing today, is looking at that systemic application. And for the next slide, please, Holly. As we talked about this in the first two sessions, and especially for today, because we're going to be focusing at application at an organizational and systems level, the invitation is not to forget about the fact that the literature is it's pretty prescriptive, that you cannot just apply trauma-informed practice or trauma-informed care just to our clients, but it is really important to apply the same principles and strategies to the workforce, again, regardless of your role or your profession. And then the next slide, Holly. It's on its way. So we use the 5 principles. So those haven't changed. So safety, trustworthiness, trust, collaboration, empowerment for both clients and staff. And the next slide that kind of crept up there, Holly can go to that, is looking at evidence-based benefits of becoming trauma-informed or offering trauma-informed services. So the first thing I want to acknowledge is that because we're coming from a pediatric healthcare setting, and all 3 of us are mental health and addictions program staff, you know, a lot of the references here are related to application in mental health services. However, if you look at some of these, so the third bullet down is the cost-effective treatment, so you can replace treatment with services. And I remember a conversation in one of my breakout rooms where an example was shared that, you know, for some of the services that you may be supporting your clients with, there may be a federal level of engagement, a provincial level of engagement, and then your own organizational level of engagement, which means that at some points there may be some redundant practices which are required, obviously, or it wouldn't exist, but to also think about it in terms of how that might apply for you folks as well. And then for the last bullet point, it's saying decrease patient use of acute care and crisis services. So if you don't work in a hospital setting or healthcare setting, you can still think about the need for some of your clients and families to access, well, actual EHS or first responder services, or even things like food banks or emergency shelters, depending on what their specific needs are. So I just want to kind of clarify that when we talk about the evidence-based benefits, that it doesn't have to be just about, you know, the impact on mental health and mental illness and the treatment of it. It could be transferred to any profession or domain as well. And then in the next slide, what Holly's going to start to do is to take a bit more of a focused look at the application of trauma-informed care at an organizational level.
Thanks so much, Prasanna. So yes, as Prasanna mentioned, in the last few sessions, we focused on the clients and families and the staff and a bit about organizations. So what we want to do is take you through a bit more about organizations and what at that level should we be thinking about, and some suggestions that you might be able to put into practice. So the first thing we want to talk about is trauma-informed leadership. So really at many levels, this is really important. It's important, as we talked about, for us to have the understanding of the awareness, the impact of trauma, and how it applies to, you know, the clients that we work with, our staff, and ourselves. So again, the leadership, it's really important for them to understand that and the prevalence of trauma, and also the impact on themselves. So we're thinking, again, holistically of how we're all human and we're all impacted by trauma. And as leaders too, we need to have that time for self-reflection to see how this may impact us, how it may impact the staff that we support, and our clients, and so on, depending where you work. So that's one point we wanted to make. The other big piece for leaders is really thinking about, how do these principles of trauma-informed care show up? So how do they model that? So how are leaders creating those safe spaces for the staff? How are they creating, you know, transparent workplaces? How are they creating and maintaining trust and choice, collaboration, and empowerment? So how is that showing up in their leadership kind of style and how they model leadership? when they meet with staff? How is that showing up when we do performance reviews or evaluations? How is that showing up? So really thinking about, for leaders themselves as individuals and how they lead. How does trauma-informed care show up in their day-to-day work? And also the impact of trauma on the workforce, as we talked about in session 2, thinking about how does trauma show up? Does it show up in some ways because we're exposed to a lot of traumatic material in some of our roles? Does it show up that we don't have the system supports or resources sometimes to do the jobs that we want to do? So again, thinking about the real importance of leaders and organizations and how their buy-in and support and modeling really does help create that culture to build trauma-informed care, and is really important. And as we say, the leaders are taking care of the staff, we also have to acknowledge too, we also have to take care of the leaders. So how in our system are we taking care of the leaders to do the great work they do and to support the great work that the staff do? Another piece we wanted to mention on the organizational level is looking at how do you take kind of stock of what your environments are looking like and how you're practicing. So as we talked about the principles of trauma-informed care, can you look at your environments and say, are they welcoming? Do they feel safe for staff and clients and the community? Are we, creating as much choice as possible in our interactions? So this checklist is a way, and this was sent out to you as well as a resource, so you can take a look at it to see how maybe you could apply it to your organization, and thinking about how you create safety in both the physical, psychological, and cultural aspects of that, and how you create safety, again, for both your clients and staff in the workforce. So this is a way to do it. So we work with our teams and organization, we fill this out and kind of see what we're doing really well and what maybe we can improve on, and then start to look at some priorities. So what for the next year do we really want to work on? Is it kind of staff support? Is it our space? Is it, another piece of the work that we're really wanting to focus on as we go forward? So again, just really acknowledging where we're at and where we want to be. That's available to you as well. Another big piece that over time that's really important is taking a look at your policies in your organization. So this was a big piece for us as well, and looking at if we had new policies that were coming, or if we had to revisit an old policy, really looking at, are the principles alive in the policy? Are we really creating that safety for everyone, that trustworthiness, choice, collaboration, empowerment? Are we really looking at universal precautions? Are we really minimizing re-traumatization, as we talked about? So are we able to, do that with our policies? Are we able to communicate in a way and share knowledge and work together? And how do we look at the tenets of trauma-informed care? How do we look at the tenets of person-centered care or patient and family-centered care? And how do we look at diversity and inclusion? So how are we really looking at this in policy? In some ways that we have done it kind of on big levels is looking at, we used to call one of our policies that we had was like an apprehension policy, right? So thinking about that and kind of reframing it and looking at the policy and changing it to taking into care, right? So even the language of that and how that has a big difference in the way we look at that and how we treat that in that policy and the care for the people that are involved. In one of our other programs, we moved from a least restraint policy to restraint prevention policy. So again, looking at that prevention piece of trauma-informed care and how we do that. And another example that we have, as we look to be more diverse and inclusive, we were looking at our respectful workplace policies and looking at that we didn't have language in there for microaggressions, and also adding that into our policies. So again, just looking at our policies, and is it reflected in our policies what we value, right? Is that in our policies and practices and interactions as we go? So really taking a look at our policies and our organizations to say, we value this, we want to do this in our everyday practices, but do our policies reflect that? And sometimes they don't. And so it's acknowledging that and working towards how do we do that better. So we wanted to just show you as one example, and there's many others out there, but of how we look at it at the IWK and looking at 10 ingredients for trauma-informed care. So we talked a lot about these through our presentations and looking at the importance of co-creation and partnership, and that's with everyone. So everyone at every level. How do we have education for everyone? So again, we understand the prevalence and the awareness that trauma is very prevalent, and how do we create that environment to be trauma-informed? How do we lead and model? So we talked about on the leadership level, so that could be an informal or formal leadership levels. How are we all communicating with one another? How are we advocating? We talked about the safer environment. So how do we create those physical, psychological, and culturally safe environments? And how do we do that? And thinking about our workforce. So again, how do we support staff in a trauma exposed workforce? So thinking again, all those pieces that we need to do individually or team-based or organization-based to do that. So thinking about an organization, thinking about us implementing kind of peer support services and other services for staff to access to support them. Another component is addressing cultural diversity and trauma. So again, the connections and how to move forward and how we need to be investing more time and resources to do that better. Laura is going to talk a bit more about the cross-system partnerships and how we do that. And then as we move into screening, so are we asking, has someone experienced trauma in our system, and are we responding in a thoughtful way that meets their needs? And then as we talked about in session 1, moving from a trauma-informed service to trauma-specific services, how do we offer trauma treatment that is evidence-based to meet the needs of our populations? And through all this, we're really looking at also, how do we measure that change? So how do we know we're doing better, right? So are we asking, are we getting that feedback? Are we continually improving and seeing that we are making a difference? So really checking in on that in various ways to do that. So what we're hoping in our system and our organizations is to move hopefully to the healing organization. So often, and we kind of go back and forth in different ways with this, but often we kind of start off in our organizations as we're very crisis driven. We might have a lot of re-traumatization happening, a lot of storytelling happening, as we talked about. There might be internal conflict in our organizations that hasn't been worked out. Often dissatisfaction, low job satisfaction of our staff, and looking at authoritarian leadership. And then when we move into the trauma-informed realm that we talked a lot about, it's really how do we have that foundation, that shared language, the understanding of the prevalence of trauma, the nature of trauma, understanding the racial disparities of trauma. And then hopefully as we move forward, really looking into that healing organization. So are we really being reflective and responsive? Are we being collaborative as we can and partnering? Are we creating that culture of learning? And are we really examining and really reflecting and making meaning out of the past and growing together? So really thinking again about that leadership component too, and having relational leadership. So again, really thinking about the relationships that we have with one another and with our systems. And that's really what we hope to get to, and knowing that on that journey, as I mentioned, we're often kind of going from one to the other, right? In a situation or moment, we may be very much in that healing space, and another time we might be reactive, and that's going to happen kind of as we learn and grow, but we're hoping to eventually to move more towards the other end of the healing piece of it, to heal together as a system and as individuals. So Laura is going to take us through the next piece, looking at trauma-informed practice, looking at the interagency, intersectoral, and then some social determinants as well that affect this.
So Prasanna and Holly reviewed briefly the principles of trauma-informed care. So I just want to take a few minutes to consider the application of the principles such as safety, choice, empowerment, collaboration, and trust into care, and what these principles offer people who have experienced trauma personally or within systems. So just kind of a brief kind of look at this. So offering safety is a high priority for those who have experienced trauma. So people who have faced traumatic events may never feel safe, or they're always watching or waiting for harm. So safety in relationships and safety in spaces and interactions is incredibly important. For those people that have been harmed, trust can also be hard to negotiate. So it's important to be able to foster trust and supportive relationships through transparency and honesty. So think of how important it is to define what we do with our clients and discuss limits of our role, limits of confidentiality, and to not risk a breach of trust or lack of clarity that can foster mistrust. Choice, again, having choice and options, especially for a person who did not necessarily choose for a trauma to occur or had no choice when a harm was happening, makes it essential that choice is experienced. So that choice is given a voice and clients are heard as to what it is that they need in their care. And collaboration. Collaboration along with choice can equalize power differentials in care. So collaboration creates partnerships and fosters equity in the experience. collaboration also values reciprocity in that everybody can contribute something valuable, considering the person as an expert of their own experience. And empowerment provides back to those who have had control taken away. Maybe that's because of a harm or a negative experience, but they're able to regain that control through that validation, acknowledgement of their skills and resilience. Empowering others also allows for growth with a focus on resilience. So I think of Helen Keller's famous saying that although the world is full of suffering, it is also full of the overcoming of it. So not just focusing on maybe the risks or the deficits, but focusing on the resiliencies. So as we reflect on these core principles, just take a minute to imagine, what if these principles showed up in your work in ways, not just your practice with clients or families or between colleagues, and management, but what if these principles were extended and applied within interagencies, within collaborations and sectors between governments, and between sectors within the government? So what if the application of these principles were considered in policy and in program development? So as we continue to explore trauma-informed practices, I think it's really relevant and applicable, that trauma-informed programs can really be transformative at all levels. We've talked about the various ways in that trauma can affect individuals, and we've also looked at the stress responses to understand how stress can affect an individual's physiological and psychological responses. So I think of the fight, flight, and freeze response for those who face a real or perceived threat. And I think about what this response can look like and mean as it occurs within systems. So someone who may freeze could be somebody who doesn't return a phone call or doesn't follow up to appointments or doesn't show for appointments. And perhaps they are passive in making plans or defer to others and seem unengaged in identifying problems or finding solutions. Someone who may flee may also no show or not respond when there are follow-up plans or calls. They may disengage with services when feeling threatened or unsafe. And they may be the client that cancels right before the appointment, and risks losing out on services because of poor follow-through. And there are those that might respond by flight. So they might be seen as disruptive or disrespectful or demanding. They may try to assert themselves in collaborations and decisions and be seen as needy or difficult or greedy. I was working recently on a literature review pertaining to newcomer experiences of systems, and I came across a very poignant description of the position that newcomers may find themselves when experiencing systems. And the quote is, "Refugees are often faced with two options: either live in conditions of powerlessness and dependence on paltry services and assistance, or put one's life at a higher risk in quest to live with dignity and justice and with self-determination." And I've heard it being expressed in our systems, that newcomers should really just be happy for what they get. Or if newcomers ask or push for more, or really they're asking for equitable care, they are perceived as greedy or taking advantage of the Canadian system. I've seen a documentation families described as difficult for voicing their concerns and never being happy. And I've also spoke to families who face the tension between advocating for their needs and then fearing that they might face retribution for doing so. So I think the question is, how do our systems see people? Is it through a trauma-informed lens? I think we'll go back to the slide that we just passed. Yeah, thanks. So although I think these days, especially with COVID, there is the experience of sometimes isolation or working in a particular silo within health or settlement or education or social services, I think there's no doubt that we work in individual systems, but that our work in these systems overlap. I think of the ways in which justice and healthcare had to align to provide like a COVID response in correctional facilities. I think of how the settlement sector and health have to coordinate to provide services or increase capacities with regards to the flow of newcomers into the provinces. Settlement likely interfaces with many other sectors such as housing, income assistance, and other community supports. So I think of the ways that I see clients that overlap in all of these sectors as they engage with different partners and services. So one example is that I have a client who is a newcomer youth who had some interaction with the law. The youth has also had some difficulties because of behaviors and substances, and so has been referred to various mental health programs and services. Due to some of the difficulties, there's been resistance in regard to him attending school. And although he's been in Canada for a number of years, it was identified that he has trouble with literacy. So the school asked for a psychoeducational report in order to, before they would be able to create a back to school or return to school pathway. So this meant advocating for the report through the courts and asking health to provide a psychologist to fulfill the request. The advocacy continues through community services with a mentor who's following up at the school. And the clinic where the youth is located is in the settlement offices due to his family's involvement with ISINs. So you can see from this one case that the work involves engagement between sectors. Think for a second of instances where either personally or professionally, you find yourself engaged in multiple sectors, maybe looking for one solution or looking for a way forward. So as we kind of ponder the questions just posed, how do we see client systems? How do we in systems see clients? Is it through a trauma-informed lens or through a different lens? There is perhaps an awareness that a paradigm shift is needed. We need a shift to a trauma-informed conceptualization, supporting its application to like a universal precaution approach. And with this, I think thinking with newcomers, also including a culturally responsive approach as well. As we are thinking of applying this to broader systems, the reality is that systems is made up of individuals. This shift starts with us and our knowledge and understanding of trauma-informed care and of culturally responsive ways to provide services and engage with others in systems. It starts with our ability to examine our own values and beliefs and to reflect on the realization that we don't often see or know everything there is to know. It begins in our ability to be open to learning, open to feedback, open to change, and that this knowing then leads to action. It changes how we speak to others and changes how we interact with others. And what that could be a client, that could be a colleague, or that could be a system. It changes what we are willing to do. So do we offer more choice? Do we engage in ways that increase collaboration? Do we look to understand a client's response, or are we quick to assess and make assumptions? And it should change the way we value success and provision of care or service. I think at times it's easy to become frustrated or discouraged in the work as we engage and witness the incredible complexity of systems. Perhaps what is discouraging is the glacial pace at which change occurs, the policies that are behind practice, and it can feel that such change is far beyond our ability to influence. And it might be, but I often think that if we know there is a problem and do nothing, then we are complicit with that problem. So instead of feeling helpless, look to what is within your sphere of influence. Perhaps it is as simple as Arthur Ashe's idea: start where you are, use what you have, and do what you can. So as we move from an organization to cross-sectoral approaches, I think of the ways that we engage and promote and advocate for partnerships within sectors that are trauma-informed. So consider the organizations, the services, the programs, the agencies that we are connected with also trauma-informed. Think of how fundamental it is to have a shared understanding of trauma and a shared conceptualization of the impact of trauma as people engage in services and care. So do you or does your organization know and refer to or collaborate with services or programs who engage in trauma-informed practices? How do agencies and programs involved in care communicate and plan for care to support trauma and trauma-informed decisions? And what training is there to work together for sectors to come together to better understand, to train and build trauma-specific knowledge and shared experiences so that we can have improved collaboration in the provision of care? As we think to trauma-informed approaches and the idea that change starts kind of individually and moves and grows outward from there, and we consider the intersectionality of the experiences of people who receive care, that it is our intersectional or intersectoral approaches that are not just as a consumer, but a care provider. And we think the ways in which systems and programs and organizations can improve with respect to trauma-informed approaches across sectors. I would assert that as providers, we should consider our interaction within sectors and between sectors and the approach that we take, because it can also be trauma reactive or trauma responsive. A small example, I guess, to show the point that I'm trying to make is I can often feel frustrated, and I was recently feeling very frustrated trying to navigate the education system while I was advocating for a client. I was seeing this client due to decreased school attendance and anxiety concerns. And I was frustrated that the family's voice was not being heard by the school. And I couldn't really understand the delay in communication. I was told the family were asked to find their own interpreter, and if they wanted to set up a school meeting, that they needed to find their own way. And I felt that this was kind of poor care. This was a system that was not understanding the gaps and the barriers for the client. And, I was concerned for the way that they put the impetus for interpretation on the family to provide, who didn't have access to an interpreter and didn't want a family or friend to be involved to breach their feeling of safety and trust and confidentiality. So, I need to confess my first thought was really, how terrible is the system? And, and the participants, not really understanding the needs of the family. But as I met with the education sector and the educators involved, I learned more information. So I learned that education has little access to interpretation resources. And just that small understanding and those pieces helped me think and helped me understand the system's response, or what I perceived as the lack of communication or the lack of resources, and thinking of that in a more trauma-informed way. The system, in this case, the principal and the guidance counselor and those involved were really doing the best that they could with what they had available. And so as we look at our roles in intersectoral partnership and collaboration, it's helpful to be thoughtful of how we perceive other systems and how we perceive our own system. It's important to hold an understanding of where we are at, while also looking for opportunities for change and ways to contribute to the transformation of that system, to be able to keep moving towards that healing or that organizational systems approach. So just as we spoke for the need for a paradigm shift and the impetus on individuals to implement changes in perspective, interaction, and practice, this work continues to extend outwards. So we see here that trauma-informed practice is something that moves beyond systems levels and influences the environment. Continuing outwards, trauma-informed practices and principles will provide a way in which to examine things more broadly, looking at the social determinants of health and the ways in which policies and law and things like even funding priorities or grants or special programs can either work towards perpetuating inequities or can reduce them. So policies that can either be reactive or they can be proactive. Looking at the social determinants of health, we know that people who experience an ability to access these basic needs will face poor psychological and physiological outcomes. When I think of the newcomer population and some of the literature that speaks of newcomers facing mental health symptoms and distress, one of the things that is known in the literature is that there may be symptoms of mental health concerns, but it is not necessarily reflective of a mental health condition, but rather the symptoms are the reality of living with the stressors of unmet needs with respect to the social determinants of health. So providing for those needs, providing equitable and consistent access to the social determinants of health actually remove the stressors and the symptoms disappear, and they don't perpetuate or they don't develop into a mental health disorder. So my focus is on mental health, and so I find it interesting to see how the literature identifies risk and protective factors. For instance, ensuring that a newcomer has access to education and language development, English as an additional language or French as an additional language supports. It really helps a youth that is able to acquire language to be able to establish and form their identity. This is connected to their mental health and well-being. Their well-being is also connected to their parents' mental health, which is impacted by their ability to navigate employment and housing and having access to peer and community supports. So recently I was talking with a newcomer that I provide care to who uses a mobility device. And, she was just sharing with me her struggle of finding a house that was able to have some accessibility. So not being able to have a house that is accessible resulted in her father having back pain from having to carry her from floor to floor in the apartment. And there was little income to really make their house more accessible. And how this situation for accessible housing can amplify other inequities and stressors that the family faces that impact their overall well-being. I also think of how challenging it can be, say, for instance, for newcomers to access health services and the red tape that might surround things like accessing the resources in the IFHP plan. So in looking at the social determinants of health, whether that's childhood experiences, housing, education, social supports, family income, employment, community structure, and access to services, you can see how all these factors are interconnected and how important it is that policymakers understand the connections between lack of these supports and perpetuation of poor outcomes that really cross all sectors of care. Also, how important it is that policymakers see that resourcing funding programs or services that support these determinants can also have short-term and long-term positive impact. So just looking briefly to ACEs, so the adverse childhood events or experiences, and just remembering that 1 or 2 ACEs experience can lead to long-term negative outcomes. We know here that ACEs is not restricted to one event or one environment. ACEs really shows up in many places, including the home, the community, and the environment. So this slide gives some really good examples. We know that these stressors, if unaddressed or unsupported, may ultimately place increased burden that might overwhelm a person's ability to cope, or might, overwhelm a person's ability to utilize their resiliencies. I think of newcomers again, where the literature has noted that they often face multiple ACEs. I think one study identified that it's at least 4 or more ACEs that are experienced by the majority of newcomers, and the things that they have faced in pre-migration, migration, or acculturation. And this just really underscores how incredibly important that when newcomers move through acculturation, when they are here in Canada, that there are not additional burdens faced in the community with households, within their households or the environment. So what can be done about ACEs? It seems that at times I feel sometimes that there's such focus on maybe the risks, the vulnerabilities, and the negatives. But I've mentioned previously that one of my favorite truths in psychiatry is the understanding that predisposing events are not predictive events because of protective events. So when I'm focused on the predisposing trauma or the perpetuating traumas that continue to occur with inequities or the inability to acquire social determinants of health, I have to remind myself to also think of the protective factors. So what are the things that can be done that are protective against things that have already occurred? So what are the things that we can do in our own work, or what are things we can advocate in larger systems to make available? So I think of some of the things that are listed here, like safe, stable, nurturing relationships, that, this is really primary and has a huge impact on reducing harms from trauma, to help to build and develop and be protective factors against trauma. Look to clients and how they connect to parent programs that will build their skills and capacities to provide safe home environment. Look at addressing stigma around mental health and providing connections to the resources that are available locally, and understanding the cultural components and maybe the barriers that might impact a person's understanding of health or mental health. And thinking of other programs that link families to high quality childcare, or ways that, families can access funding to supplement difficulties with their income. What provides me with great hope is remembering that people who have survived trauma, or I think of newcomers who have faced incredible challenges and are arriving in Canada and continue to face stressors, are incredibly resilient people. So I look to find those resiliencies and build on them. I look to advocate in my program, and I would say look to your programs and advocate in what's available in your services, as in terms of services within your community. So as we know the protective factors, we can advocate for broader political change, for things that, would reflect change in policy, things that would see an increase of funding to allow for development of these supports in the community. So I'll pass it back to Holly, I believe.
Yes, thanks so much, Laura. So yes, we really want you today, we always start again, as Laura said, with ourselves, of how we can make change and how we can help, our teams and our organizations. And then hopefully, as we look to the broader kind of society, of how we're kind of working together and within our intersectoral and agency teams. And our hope really here for trauma-informed care, as the quote says, trauma-informed systems, principles, and practices support reflection in place of reaction. curiosity in lieu of numbing, self-care instead of self-sacrifice, and collective impact rather than siloed structures. So that's a really our hope and kind of message today is, to think about how trauma-informed care looks for you kind of individually at your team, organizational, and systems levels, and thinking about how we can, remove some of those silos and work together to partner to meet the needs of the people that we're working with in the communities. So that is our piece today of looking at some of, the literature and what's out there and having some conversation about trauma-informed care at all of these levels. And what we're going to switch to is going into some groups, and we're going to look at these 3 questions. So looking at what are the existing trauma-informed practices which work well in the system you're working with and working in, right? So what is working well? What are some barriers for your clients that you work with and their families and communities and systems that kind of make it difficult to maybe do trauma-informed care the way you'd want to? And then looking at some ideas or strategies to improve that integration into your system. So we're going to go into 3 groups and be looking at all of these questions. And we're going to be taking about, I think 15 to 20 minutes to kind of do that. And then we will come back to the larger group and report back as to what we were talking about and share our learnings with the group. So Mariah, if you're able to help us into the groups, that would be appreciated. Thanks so much. Welcome back to all of our groups. I know my group had a great discussion, and Faye was nice enough to help us to take some notes and to do some wrap up there. But I think we'll start with, I know Prasanna and Laura were in the 2 other groups as well. So maybe Prasanna, I'm not sure who in your group was able to take some notes and write down some ideas, or who wants to speak for the group.
So that would be me, because halfway through I realized I didn't invite someone to take notes. I was like, I'm going to start taking notes, but I already told my
all
folks,
good, all good.
help me out if I don't report things accurately. So Holly, am I just going to cover the items we talked about for question 1? Is that the idea, or?
Sure, if you want to do that, if there's anything specific that you want to highlight, that's fine as well.
Sure. So for the first question, in terms of the things that are already in place, one of our participants talked about in Ontario, there is a local integrated I guess process or procedures for referrals. So it can help me out, Deborah, which provides a holistic approach. And the point was that if a certain service knows about even what the other service is able to offer, or even better, knows some folks there, that the referral process is that much better and safer for our clients. Another person talked about that they're starting to become trauma-informed. And I said, that's a good place to be, because we all have to start somewhere. And so the idea was that those folks are becoming more aware and providing better care for clients and staff, and specifically it was around basic knowledge transfer. So even terminology, looking at physical spaces like we talked about in this session 1, about waiting rooms, and then they talked about making spaces in children's hospital settings more kid friendly and nicer, but then also talking about access to interpreter services, so that there's no miscommunications around important things like consent or even general communication. And then someone also talked about the importance of choice, even for children. So we want to make sure that children don't get hurt, but that's not the type of choice we're talking about. It's giving the person the ability to have some agency and control of their environment. Yeah, so those were the items we talked about for question 1. Is there anything?
Yeah, is there any other highlights just for maybe 2 or 3 that you wanted to?
Oh, from the other 2 questions you mean?
Yeah, just if there's anything highlights that you wanted to cover.
There were lots of good ones. All right, folks, I'm just gonna pick the middle one randomly. Talked about the amount of time that a person may have with a care provider, so specifically in a healthcare setting, but it could be with any provider, if the system dictates the amount of time that the provider is allowed to spend with them. So in Nova Scotia anyways, with family doctors, there is a funding formula which talks about, right, a GP is only allowed to have a certain number of, so air quotes, counseling sessions before they have to refer somebody to mental health services or psychiatric services. And as I know, but if I'm happy with talking with my GP, the assumption is that there's a relationship there, there's trust there, and that the system now requires a GP to make a referral, right? So just as an example, and then along the same lines, I was also talking about power dynamics, and especially looking at generational differences. And some folks may feel like, great, well, they're a doctor or they're a teacher or they're my settlement worker, so I have to do it, and not really question the care provider, right, and their instructions. And for the last question, in terms of things that are that could be improved, talked about the importance of language, and even making small changes to language, whether it's on websites or print material or signage. And another important point that was made was to make sure that all staff have training, and then I offered, it's not just training, but to make sure that it's a standardized training so everyone has the same language and common base of information, if you will. So the few things, I guess, for question 2 and question 3.
Perfect. Thanks, Prasanna, and to your group. And Laura, was there someone that was going to speak from your group?
That's me again.
Okay.
So
So highlights on all of them would be great if you're able. Yeah.
Okay, I'll do my best. Hopefully I don't leave out anybody. We had a great discussion, so hopefully I don't leave any salient points out. But in terms of kind of what are some of the things that are already happening or some of the practices that are working well. So there was an example of like a PEEPS program. So from CHIO, I believe, where it was, if you're like a clinician or if you're a staff and you're facing a question of moral distress or you're facing a difficulty in your workplace, you could call this line and you could have somebody that's gone through some training that would be able to guide you through maybe that question or that difficulty or that distress that you might be facing. I think there's some other examples in terms of providing different things in higher education, so like transformative education and kind of moving beyond just an academic approach and a lens of seeing students, but also kind of integrating academics with emotional responsiveness and other ways of kind of taking into account how emotions can influence what shows up in the learning as well. So kind of looking at more of a holistic approach, and also recognizing that right now, if you're just only identifying students to be referred to a counselor, that maybe there's a more transformative way of looking at addressing that. And I'm trying to see other things that were going well. I think just having opportunities to I would say in our system, having access to trans interpreters would be a real positive, and I think that also speaks to the next question, maybe of some barriers where other agencies or sectors or organizations may not have that same opportunity. So kind of seeing that works well in terms of accessing resources for that. And it was also mentioned in terms of what's working well is just putting into place reflective practices. So the importance of reflective practice to really help people identify kind of their own perceptions, their own ways of thinking and knowing, and being able to kind of discuss that with peers and colleagues in a safe space to kind of further that, that personal insight. And then as you approach care, you approach your work, you have that kind of as a grounding. So those were some of the examples of what is working well. Some other examples of the barriers would be just finances to implement certain programs. That is a barrier. Just shifting people's thinking to understand that this is important. I think, there's an example of, although there is a trauma-informed committee, it's trying to get buy-in from other colleagues and other leaders to make it that, to help them understand that it's important, and also the time it takes to maybe change policy when there's an identification of a problem. So again, an example was taking a history in the emergency room. It might be difficult for that client to repeat that history that could be traumatic many times for different care providers over that interaction. And yet care providers would also say, but we need that history to provide comprehensive care. So that balance between the client's needs and the colleagues' kind of need for care, and kind of seeing, how can policies change to support more trauma-informed approaches or ways of kind of approaching those situations. Other strategies that were really positive are just some courses around trauma integration and transformational leadership courses. And then there's an example, I can't remember what the course was, but where there's kind of practicing mindfulness and practicing some of those approaches, and providing that for others to practice and to kind of be aware of and know about. I think it was within the context of a course, and so kind of putting that out as a formal kind of piece for people to engage in. As for things to improve, I think there are a number of things that people have in terms of ideas of how they can improve. So I think the one point was kind of just practicing it and kind of holding yourself accountable, holding other people accountable to be practicing with a trauma-informed lens. Those were some of the things that kind of were put out there to, how do we continuously think about improving things? So those were some of the ideas that our group had.
Great, thanks, Laura, and to your group. That's great. All right, and for our last group, we have Faye, who's helping us to write and capture our thoughts.
I think there's a lot of crossover points that everyone else has shared. A few of the things that we have, especially with regard to the existing, is policies about restraints that are already in place, having a trauma-informed committee that I think somebody else raised at the hospital. The training for frontline staff, I work for ISEM, so we mentioned that. And then one of our colleagues, Kat, also indicated that they have it as a national policy. It was a really great good practice that they work on for all volunteers. It's the assumption of ACEs, and they receive trauma-informed care training. So that's just absolutely amazing, especially for volunteers. We were really happy to hear that good practice in place. There's also a child life workers specific to assisting with distractions and working with the child. And one that is a strength, but then it's going to come up again later, is that patient family advisors and families that sit on committees. So I'm going to roll that into the barriers, because that was raised not only as a positive, but also as a challenge, because newcomers may not understand the construct of a board or board development, and it may not be the most effective way that we can actually engage with newcomers. They've come with their own set of strengths and weaknesses, but putting them on a board may not be something that they're familiar with in a way that's going to be constructively moving forward any of the initiatives that they think might help. The other barriers that we had discussed were individual workers. They may have lived experience or experience, but they may not be formally trained. And sometimes there's variation in the type of training that's put forward. That lack of collaboration that other people have mentioned and that we discussed as well means that sometimes you're not all singing off the same song sheet, you're not all working off the same platform. gaps as well, considering parents instead of just children when it comes to doing trauma-informed work. One of the examples that was provided was a triggering song that came on the news reel for the television shows that triggers for the parent the loss of their child, and how we're not working towards identifying those types of gaps and working with families and getting them through this. The other issue, and I think it was raised again earlier with one of our other teams here, was that everyone seems to think that, oh, that's a mental health issue. We'll just put it over there and they can deal with that. Instead of looking at it as a multidisciplinary, multi-engaged event that requires collaboration, that requires us to work together and to work on the same song sheets, that we're addressing the issues on all levels and all ways that we're engaging these people. So I'm going to switch us over here to a couple of the really great things that we started off talking about that could be opportunities for assisting and moving forward. We did get cut off, so not all of our conversation was captured there. Interactive and scenario-based training. And as we talked about for one of our gaps, is if we could have that as a multidisciplinary event would work. Collaborating with the different providers, the multidisciplinary providers, and ensuring that teams are actually trained in the same way, that we're collaborating on providing the services, and finding new ways to engage the newcomers besides the boards, which we talked about, rolling over from our weaknesses that we identified. And then having partnerships and philosophies and goals that are system level, more so than just individual teams. And I think a lot of that has been captured by everyone else. We're all identifying all the right things to do forward. And I'm going to close us off there unless I missed something else out from the team, if you want to jump in and add anything.
No, you did an awesome job, Faye. I think you captured everything that we talked about. Yes, getting lots of thumbs up here. Yeah.
Excuse me, Holly. Just wondering, just looking at the time, just want to insert in one more comment that our group had for question 2. I don't think the other 2 groups brought this up, is around the need for staff training, but the need for training for upper management and senior leadership, because that influences decision making and funding, which then impacts the ability for direct care providers or direct care providers to spend more time with clients or to make changes, so on and so forth. And the other one thing was also around the staff wellness piece. Again, making that shift from, right, it's not a luxury to focus on staff wellness, but especially with the pandemic, is that everyone's doing their best to begin with. But yeah, so the main point was that focus should also be on training for leadership.
Yeah, thanks for adding that, Prasanna. Well, thank you everyone for, the very enlightening discussion. And I think, there's things, and our hope is that today, this is just kind of the start of the conversation, and how we, think about this and reflect on it in our own practices and our own relationships and environments. And then how do we take it to our teams and our organizations to say, I attended this session or this series, and now how can we take some of this learning and apply it to our own work areas? And how do we, all stay connected and support one another to do this great work that we're all doing? So we're very happy to do that as well. I'm just going to pull up a slide here just as we close. And just say, we are really looking at how do we do this on every level, as we said earlier today. How are we doing it on the client and family level? How do we support staff to do the great work that they do? How do we support leaders? How do we support the community? How do we collaborate as systems to do this work? So that's really what we're looking at, and really acknowledging, again, as we mentioned before, that resilience. So resiliency is there and does show up. There's just a little delay there. So this is our trauma-informed care team. And these are all our great members that we have on our team. And you can see Prasanna and I are already there as well, and many others that contribute greatly to our team and to our work as we work in our program and our organization. And if you would like to have more information, we do have a website. So it's yourexperiencesmatter.ca.com. You can reach us there. And we also have an email as well if you want to be in contact with us. And we're happy to stay connected and to continue these great relationships and conversations that we started over the past couple of weeks. So please contact us and reach out, and we're happy to support and continue these great discussions. So I think Mariah has a couple of closing slides there as we transition out.
There we go. Yes, I just want to give a big thank you to our facilitators, Prasanna, Holly, and Laura, for an incredible 3 sessions that you've provided. I think these just flew by, and I'll give you a virtual applause, and I hope others will join me. But it's really been so wonderful having you these past 3 weeks and having you share your knowledge with us and do it in a way that's really engaging and interactive. I know that I personally have taken away so much about what trauma-informed care can look like in practice, and where there might be some system and organizational barriers as well to that. So thank you so much. And to all of those who signed up and joined or watched recordings, thank you so much for joining and making the time to engage and learn about this really important topic. We do hope to see you at future N4 learning events. And I have shared some just on this slide that are upcoming in the new year. So there's ethicist-led case-based learning with a bioethicist, Dr. Michelle Mullen. We're also hoping to have a panel discussion on navigating the 2021 Afghan refugee crisis, lessons learned from the past to prepare. And also upcoming in March is N4's first conference ever, and there'll be no cost to join that. It's sponsored by, registration costs are sponsored by IRCC, and more information can be found on our website. And once again, if any of you are interested or have not yet signed up to join N4, there is no cost to join, and that's where we'll be taking the past 3 sessions and packaging them into our e-learning side of our platform, and we'll include any resources that our friends at IWK have shared. So with that said, I think this has been a great 3 weeks, and I'll just give our facilitators the final word. So Prasanna, Holly, or Laura, if you have any final words for the group, I'll hand it over to you, and then maybe we can wrap up.
So thank you everyone for sharing your time and your knowledge and your expertise and your learnings with us. We learned a lot as well. So thank you for joining us today or the past 3 weeks. We're very happy to be with you, and again, want to continue these great relationships.
Thanks, Ruth. Yeah, so same sentiments. Just also want to thank Mariah and Andrew for organizing things and keeping us on track. So that support was really helpful. As thinking Holly, also want to thank Laura. So in terms of our, I guess, collaborations, we're partnering with other services even within our. So I want to say thanks to Laura for stepping up and sharing your expertise with newcomers as well. Thanks,
Yes,
everybody.
amazing. Thanks, Laura.
It's been a great 3 weeks. So yeah, I appreciate the opportunity and really for N4 to making it available, right? So I'm putting it out there. So that's awesome.
Wonderful. Well, thanks so much, everyone. We hope that you stay safe and well, and happy holidays as well. Okay, I think it's just